So as Jan said, my presentation is on the practical management of food-responsive enteropathies and how to perform proper diet trials. So I've just listed my disclosures on this slide. So as an overview of this presentation, which is how to perform proper diet trials, it really focuses on three main areas. So in order to perform a proper diet trial, we really need to focus on these areas. So firstly, we need to make sure we're selecting the most appropriate diet for the patient. That will allow us to ensure that our diet trial is going to be as successful as possible. And then we want to ensure compliance from both the owner and pet, and so we'll talk about ways that we can improve that. And that will also ensure that our dietary trial is done properly and hopefully that it's a success. And then the third area is making sure that we assess the appropriate variables, and we know what the next steps are based on those variables. So either the patient is going into remission, what do we do next? It's partial remission, what do we do next? Or there's no response, what's the next steps? So these are the three key areas we're going to look at in this presentation in a little bit more detail. So the first area is selecting the most appropriate diet for the patient. And as an overview, I focus on three main areas when I'm trying to select the most appropriate diet for my chronic enteropathy dog or cat. So the first thing I'm doing is getting a diet history, or just looking at the different diets that have been tried in the past. And this is important because you kind of want to correlate what different strategies have been used in the different diets in the past and what response that's had. So what's helped or what's hindered. And that will allow you to determine what strategies are left to try or what strategies should be prioritized based on the response. And then we look at the case characteristics, or what the dog or cat is doing presently, and that will help us determine what strategies, again, we're looking to incorporate in that diet. And then knowing what diets are available, we can look at all the different strategies we want, and then knowing what diets are available, that will allow us to make that initial choice. So we'll look at these three areas in more detail. So the first is getting that diet history, and we always talk about how crucial this is. And what I hear from a lot of people is that this takes time, and we don't always have a lot of time in our consult. So how can we do this in an efficient way to try and get the pertinent information that's going to help us? So again, with the diet history, I like to focus on three main areas. And so the first is just really trying to get a general preference of that patient. What does that animal, what does that dog or cat like to eat generally? This is particularly pertinent if you have a cat. And we've definitely been in scenarios where we've picked the diet, we've gone to all that effort to pick the diet for the patient. We go into the room with the owner and they tell us, oh, my cat will only eat wet food, or it will only eat dry. And if we had that information up front, then it would really help us so that we know what we need to fulfill, whether this is a cat that will only eat wet food or this is an owner that only wants to feed wet or wants to feed both. That's really important to ascertain up front. Cats in particular may have preferences to certain textures or flavors. Again, knowing that upfront might help us prioritize certain formulas. So some of the gastrointestinal therapeutic diets, some of them cater for this. So they may have chunks and gravy or pate style canned food. So knowing that may help you prioritize one formula. So just trying to get the general preferences of that patient. And then the other area to focus on is to correlate any previous diets that were fed for the gastrointestinal signs, correlating those to whether that helped or hindered the gastrointestinal signs. And this can vary how much work we put into this. So if time is tight, which it can be, as a minimum, what I like to do here is just to ask the owner, have they recognized any diet that's helped the gastrointestinal signs the most? Because owners, they like to try different things once their animal has diarrhea. So they might recognize a grocery brand or a therapeutic brand that's really helped the gastrointestinal signs. And having that information may allow you to ascertain what strategies you may want to prioritize in the next diet that you use for the trial. So what we're looking at, if the owner identifies a particular diet that's really helped, you can look at the ingredients, you can look at the fat content, you can look at the fiber content, and you can look at whether that was a low fat diet or a fiber enriched diet, and like what strategy was it that was kind of correlated with that improvement in clinical signs, and maybe we're going to try and incorporate those strategies. And then finally, what I try and do when I'm taking a diet history is try and get an inventory of what therapeutic GI diets have been used already for the chronic enteropathy. It really amazes me that when we try and get diet histories from owners, if we don't specifically ask about therapeutic diets, they don't always include that. So this happened to us last week, where we had an intern that saw a case and she got a really nice diet history, and we picked a diet for this dog with chronic enteropathy. And we went back into the room and the owner said she'd already tried that, but they hadn't told us that up front. And it had turned out that the owner had tried lots of different therapeutic GI diets, but for some reason they didn't tell us that in the diet history. So I like to really specify what specific therapeutic diets have been tried for the GI disease. And I want to ask them how compliant they've been, because the amount of times owners haven't done it exclusively, and then we go back and we try that same diet exclusively and the patient goes into remission. So that's important, that if they say to you, okay, we've tried this commercial hydrolyzed diet, it didn't work. If they didn't try it exclusively, then it could still be a diet that is an option for the patient. So that's really important to know. And also the duration, sometimes owners don't do it for long enough. So if they've only done it for a few days before they gave up, then again, that diet may help if we go out to at least 2 weeks. So getting that information will help you determine what therapeutic diets have genuinely been tried and failed. Next is looking at the case characteristics. So this is what's happening presently. So what we want to look at is the animal signalment. So this is important. For example, if this was a dog that was growing or a cat that was growing, so a kitten or a puppy, we would want to feed a diet that's formulated for growth. And the easiest way to do this is to look at the pet food label. And if you see feeding recommendations for a puppy or a kitten, then you know that diet's formulated for growth. So that's important, because some therapeutic diets for chronic enteropathy are formulated for growth, some are not. So if you're dealing with a growing animal, then you need to obviously prioritize those formulas. So that's important information. What the animal's appetite is doing. So if this is an animal that doesn't have a great appetite, so it's not eating its normal caloric requirement, we may prioritize formulas that have a higher caloric density. So what that means, they have more kcals per gram of food, so that ultimately we're feeding less volume to meet that animal's energy needs. Or we might prioritize a diet that has less fiber, because fiber might dilute the calories, so you might have to feed more volume. So that's the kind of considerations we may have depending on what appetite's doing. And that's similar with what body weight and condition. So if the animal is losing weight, or they're cachexic, or they have low body condition, again, you might want to feed more calories. So you might prioritize a formula that has higher calories per gram. In terms of the gastrointestinal signs themselves, so if you have a patient that's vomiting, regurgitating, or nausea, so these are upper gastrointestinal signs, we might want to prioritize a formula with lower fat to try and hasten gastric emptying. So that might be a dietary strategy you might be looking to incorporate in your diet that you choose for the trial. If the patient has diarrhea, we always want to characterize that as small bowel, large bowel, or mixed bowel. Again, knowing if it's large bowel or mixed bowel, that might help to prioritize whether we do a fiber enriched approach. So that's important. And then again, is the patient losing weight? Is it weight stable? Because that's going to determine how many calories we're going to feed. And again, caloric density may play a role in that. So that's kind of how we use the case characteristics to decide what dietary strategies we want to incorporate in the diet we choose. And then the final thing we want to do is we want to look at the diet categories that are available for a patient with chronic enteropathy. And what I do is I kind of have a list in my head of the pros and cons of these different categories, because once I know what strategies I want, based on the diet history, based on what the animal is, gastrointestinal signs it has, I'm then kind of doing a quick checklist in my head of the different pros and cons of the different categories, and then I'm prioritizing a category. So I'm just really quickly going to run through the pros and cons of the different categories for chronic enteropathy, just to make sure we're all on the same page. So the big categories we use are the gastrointestinal diets, hydrolyzed protein, novel protein, home prepared, and then fiber enriched. So let's start with commercial therapeutic gastrointestinal diets. The advantages of these diets is that they are considered to be more digestible. They may be less expensive than some of the other categories. What's nice about these diets is that the intact protein means that they have higher palatability than some of the other categories. And in the UK, so this is different in the States, some formulas have, well, sorry, this is the same in the US and the UK. Some GI diets, some formulas have low fat, but why this is particularly pertinent in the UK is we don't have, and we'll talk about this when we talk about the hydrolyzed categories, we don't have a lot of options for low fat hydrolyzed. So this is why this category is a little bit more advantageous for us in the UK, is because this category has low fat formulas, which can be helpful when you want a low fat strategy. The disadvantages is that there was one study that compared therapeutic GI diets with commercial hydrolyzed protein diets in dogs with chronic enteropathy, and both diets induced remission at the same rate, but the hydrolyzed diet kept those dogs in remission long term compared to the therapeutic GI diet. So there is this concern that based on that one study, these diets, that ability to maintain long-term remission might not be there. So typically I'm using this category of diets. If I have a patient, so if I have a dog that doesn't have a great appetite, doesn't want to eat a hydrolyzed diet, I will try this diet. And then when they go into remission, I might switch over to a hydrolyzed formula. Or if I want a low-fat formula, I will go with this. So if the patient had lymphangiectasia, intestinal lymphangiectasia, I might start with this category. In cats, we don't have the same information in terms of whether cats on these diets come out of remission. But what we do know is cats with chronic enteropathy can go into remission with therapeutic GI diet. So with cats, I'm a little bit more willing to use these diets as a first off, especially again in the UK, because this category, we have some tinned version formulas available, which we might not for some of the other categories. So for cats, I'm a little bit more readily using these kind of this category of diets. And then for novel protein diets, the biggest advantage is that anything novel for the patient will increase palatability. So again, if you have a patient that's not eating well, trying this category may help to improve intake. And we know that there's scientific studies in both dogs and cats which show about a 50 to 60% response rate in chronic enteropathy. So that's a pretty good number. So we know that these diets can get dogs and cats into remission. The biggest disadvantage is you need an adequate diet history to determine what antigens that dog or cat has been exposed to know what would be truly novel for that patient. And so if you suspect that you have a chronic enteropathy case that could be food allergic, this is important to make sure you're using a novel protein that it's not been exposed to previously. Some formulas may have higher fat content, so if you want to incorporate the low fat strategy, it may be difficult with this category. And then anecdotally, I've just felt that with this category of diets, I feel like they sometimes do relapse after a period of like 6 to 8 weeks, and then I have to switch out. It doesn't happen in a high proportion of cases. It's just something that I've noticed. So I feel like this is something we need to look at, but maybe there is this concern that they may relapse and you might have to change the source. With regards to hydrolyzed diets, the biggest advantage is that we don't need that diet history. There's less chance of relapse anecdotally, I find. I feel like we've had canine and feline patients on hydrolyzed diets for years, and I don't feel like they have that kind of relapse where we're having to switch out. Scientific studies are anecdotal experience. We've seen a 2/3 response rate. So what we say is 60 or 2/3, 66%. We have some formulas in the UK that are controlled in fat. In the US, you have some low fat formulas, which can be advantageous. Disadvantages is the reduced palatability. I would say probably about 1/5 to a quarter of cases, so maybe about 20 to 25% of cases, when we try to transition to a hydrolyzed diet in dogs, we haven't been able to because of reduced palatability. In cats, I feel like our success rate is higher than dogs, which you would expect the other way around. But I feel like with cats, we probably have about a 90% chance of getting them onto a hydrolyzed diet, because we do kind of a slower transition. But with some dogs, it's been harder. So I did a study in dogs. We did a hydrolyzed diet study where we had like 120 dogs, and it was a quarter that we couldn't transition. And we did a study in cats looking at hydrolyzed diets, and we had 42 cats and only 3 we couldn't get to eat the diet exclusively. For some formulas, particularly in cats, there may be limited canned formulas available. So if you have that cat that will only eat wet food, that might be difficult. It may be expensive compared to some other categories, although that might not always be the case. Therapeutic fiber-enriched diets. So there are multiple studies showing that these can help induce remission in chronic colitis and enterocolitis cases. The studies have also been shown that they are safe and well tolerated. So sometimes there can be a concern with fiber-enriched diets, particularly diets that have higher viscous fibers, that they can cause delayed gastric emptying. So if you have a dog that has like upper GI signs, then it could exacerbate that. And we have seen that occasionally happen with, for example, when we've had brachycephalic dogs that have had colitis, and they've also had kind of regurgitation, then we've switched them over to fiber enriched. Sometimes the regurgitation has got worse. That hasn't happened in every case. It's just something to be aware of. The response rate with fiber-enriched diets can be relatively quick. So in one study, mean of 8.5 days, in another study, 1 day. So that those are really quick response times. So if you have an owner where you want to try a fiber-enriched, as you're either trying it as the second or the third diet trial, then you can let them know that you might see a relatively quick response. So that might help with the compliance for that diet. Disadvantages is in some dogs, when we've tried to transition over to just their normal well-pet or grocery brand diet, they have relapsed, and so longer-term supplementation may be required. With the fiber enriched, you may have reduced energy density, so reduced calories per gram, so you might have to feed a larger volume. So if the patient is inappetent or under condition, you may have to consider that. It may delay gastric emptying, particularly the viscous fiber, so just be conscious of those cases that also have upper GI signs, and make sure that that isn't worsening. And finally, the home prepared diets. The biggest advantages is their increased digestibility and increased palatability. We can use ingredients that are known to be palatable for the patient. It allows us to precisely set macronutrient profiles. So we're in charge of where we want to set the fat level. So we can set the fat level lower than what's available in a commercial therapeutic diet. So we have that flexibility. If the patient has a comorbidity, for example, kidney disease, we can decrease the phosphorus content, and so things like that. So it allows us to it allows it to be more custom made. The other advantages is it may avoid antigens from processing. If you have a case that you particularly think, it may be responding to antigens from processing, if it also has concurrent dermatological signs and you think it could be truly food allergic, and you want to try a diet without antigens that were unmasked or developed during processing, then you could try a home prepared diet to try and diagnose and treat those cases. I don't think that's common though. It's just something that theoretically could be present out there in that kind of umbrella term of food responsive enteropathy. The biggest disadvantages with these diets is access to a board certified nutritionist, especially if you're living in a country where there's not many. It can be more expensive than the commercial diet. So there was a study which showed this. Labor intensive. I always say I don't even cook for myself every day or even batch cook. I sometimes find it difficult. So to do that for a pet, I think sometimes owners may not realize the amount of work that goes into that. Again, I do feel like anecdotally, and this is just anecdotally, and I do want to look at this, I do feel like sometimes they do well on the home prepared diet, and then we have to change the source of protein, especially if you're using a novel protein home prepared diet, that after around 6-8 weeks, we have to try another protein source. So there is that chance of relapse. Source of novel protein, especially if the patient has an extensive antigen exposure list, finding something that's really novel, and then for the owner to find that consistently throughout the year might be difficult. And then finally, the bioavailability of these diets. They are very custom, tailor-made to that patient. We haven't tested bioavailability, so we do need to keep a closer eye on these patients when we're feeding a home-prepared diet, just to make sure it's maintaining body weight. We do recommend regular blood work as well in these patients. So I've talked to you about how I go about trying to select a diet for my patient with chronic enteropathy when I'm doing a diet trial, and how it's important to try and get that first diet right to get to make sure that that diet trial is a success. So what I want to do is I just want to go through a case example where I highlight these principles and kind of highlight what I spoke about and use it in a case example. So this is a 3.5-year-old male entire border collie with chronic intermittent large bowel diarrhea since he was 5 months old. And episodes used to occur every couple of months, but now the owner says they're marked, and there's a marked increase to every couple of weeks. Appetite's normal and the patient's weight stable, and we did our typical investigations, so your complete blood count, biochemistry, ACTH stimulation test, serum cobalamin, urinalysis, fecal parasitology, abdominal ultrasound, and we didn't find any abnormalities, so we suspected that this dog had a chronic enteropathy. So I'm just going to go through this quick overview that I talked about when we're trying to select the most appropriate diet, look at the diet history, look at the current case characteristics to decide what strategies you want to use, know what diets are available to make your initial choice. So let's look at the diet history. So the owner reports that the dog showed minimal interest to one commercial therapeutic hydrolyzed diet before she switched to a well-pet dog food. So she hadn't really tried that hydrolyzed diet for long enough. So what I took from that is that that could still be a diet that we could use if it had all the strategies we ultimately want. So because time was of the essence, we asked her, what one diet historically do you think's helped the most with the gastrointestinal signs? And she identified this diet. For the purposes of the presentation, we'll call it XXX. She said that diet decreased the frequency and quantity of defecation, and that the patient had no colitis episodes on that diet up until the current episode. So I looked up this diet online. I tried to get as much information from this diet as I could. And so this is the analytical constituents, and then I looked at the composition. So what I was particularly interested in this diet is I wanted to know the fiber content, because this dog presented with large intestinal signs in large intestinal diarrhea. What I was trying to ascertain was the diet that the owner had identified as being the best for the clinical signs. I was trying to ascertain, was this a low fiber or a high fiber diet? And the reason I wanted to do that is that was going to help me decide whether I was going to incorporate fiber enriched or low residue as my diet choice. So that's why I wanted to know the fiber content of this diet. So when we compare nutrients between diets, when we're trying to ascertain the nutrient content of the diet, you want to do it on an energy basis. That's the most accurate way. So what we want to do is we want to compare the nutrient on a milligrams or gram basis per 100 or 1,000 kcal. And you can do this by getting the percentage crude fiber, or which legally has to be present on the pet food label. And then you need to know how many kcals there are in 100 grams of food, which again, depending on which country you are, is present on the pet food label. Now, I just want to say, when we're comparing fiber contents, or when we're trying to determine fiber contents in pet food, you want to try and use total dietary fiber. That's more accurate. It captures most of the fiber in the food, whereas crude fiber only captures some of the insoluble fibers. It doesn't capture and it doesn't capture any of the soluble fibers, so it's less accurate than the total dietary fiber. But for a lot of over-the-counter well-pet diets, the manufacturers don't have that information to give you. So if you call up the manufacturer, because legally they're not required to measure it, they're only required to put the crude fiber on the pet food label. They probably don't have the total dietary fiber information. So what they'll give you is the crude fiber. So we did call up the manufacturer. We asked for the total dietary fiber. They didn't have that. It wasn't unsurprising. So we had to work with the crude fibers. We had to work with what we had. And so how you convert that percentage into a grams per 100 kcal is, we know that it contains 2.5% crude fiber. So that's saying 2.5 grams per 100 gram of food, because it's 2.5%. And then, you know, in 100 grams of food, there's 355 kcals. So that's saying there's 2.5 grams of crude fiber in 355 kcals of food. And then you divide that by 3.55 to get the number of grams of fiber in 100 kcal of food. So in this particular diet, the crude fiber was 0.7 grams per 100 kcal. So I know what you're thinking, great, we have this number, but what does it mean? And so amongst veterinary nutritionists, there is no like real consensus with where we put low, moderate, and high for dietary fiber. But there is this really nice review article, and they gave kind of a guide for this, which I think is really nice. So if we look, they break it down into dog and cat on this table, and they break it down into crude fiber and total dietary fiber. So ideally, you always want to use total dietary fiber, but for this case, we had to use crude fiber. And so it's less than 1. So that diet had low fiber. So what I took from that, rightly or wrongly, was, okay, so what the owner's telling me is that the diet that improved the dog's clinical signs the best had low fiber. So I thought, well, maybe I want to stick with that approach for now and see whether I could and incorporate another dietary strategy like hydrolyzed or something else to see if I can get further improvement in that diarrhea. So that's kind of what I took away from the diet history. The case characteristics is what you move on to next to try and again determine what strategies you might want to prioritize. So this is a 3.5-year-old male entire border collie, chronic large bowel diarrhea, currently weight stable with ideal BCS, good muscle and coat condition, and normal appetite. So Signalman, it's an adult, so we don't need to worry about picking a diet that's formulated for growth. It's an entire dog, so we do need to think about that it might need more calories than a neutered dog, so we might just need to be conscious of that. Palatability, I don't need to prioritize. I don't need to really worry about that because the dog has a normal appetite. Energy density, it's a well-conditioned dog. It has an ideal BCS. I don't need to prioritize or really think about that too much. Owner said it would eat dry or tin, or can, so either's fine. Ingredients, we did ask the owner if there were any ingredients they had identified that helped improve diarrhea. They didn't identify any. You could argue that you could look at the ingredient list in that diet that they had identified that improved the signs and maybe try and go with those ingredients, because it's hard to know. There's so many variables when you're looking at a diet. It's hard to know what factor was helping. I asked myself, do we want increased fiber? Based on what information I had gleaned from that diet that had helped, I kind of said I would optimize that as the second choice because the diet history suggested going with lower fiber first. And especially this dog didn't have any nausea, regurgitation, vomiting. So there wasn't really any contraindication or anything to worry about from that perspective. So if I needed to optimize it, I'd kind of use it as a second choice. And then I asked myself, is there any, do I need to lower the dietary fat? Is there any indication for incorporating the low fat strategy? And in this particular case, I didn't see a reason to hasten gastric emptying. It didn't have any upper GI signs. There's no evidence of intestinal lymphangiectasia. There's no evidence of concurrent pancreatitis. So again, and there's no evidence of steatory or fat malabsorption. So I thought if I low dietary fat, I would optimize again as a second choice if needed. So finally, looking at your diet categories that are available. So therapeutic GI, I kind of took off the table because I wanted, this dog's appetite was fine. I wanted this dog to stay in remission a long time. So I would have chosen that, or it might have been a consideration if this dog wasn't eating or the appetite was low, or I wanted a low fat approach. I thought hydrolyzed protein would be useful for this dog, so I definitely left that on the table. Limited ingredient novel protein I thought could be an option for this dog. Fiber enriched for the reasons I spoke about before. I didn't think to prioritize as my first strategy. And then home cooked, I didn't feel like we were there yet with this case. So that's not something I would do as first line unless the owner had identified that home cooking was really, and they were doing that already, and that had really got the dog into remission and the dog was doing well and they just wanted that to be balanced. I do home cooking, but more like further down the line. Typically I would try commercial therapeutic first. So then once you know what categories you want to prioritize the formula within that category. So because I was looking at this low crude fiber, total dietary fiber, I'd probably pick the one that had the lowest. And then this is where, when you're prioritizing formula within your chosen category, sometimes you might need to consider any nutritionally responsive comorbidities that are also present, because if there are strategies there, for example, if you had a dog with chronic kidney disease and you needed lower phosphorus, that's when that would help prioritize your formula even further, because you might need to incorporate those strategies as well. This dog had no comorbidity, so we didn't have to do that. So we went with hydrolyzed protein, generally because this category has lower fiber. This dog's appetite was fine, so I felt like we could transition to a hydrolyzed diet easily. And then the anecdotal and scientific evidence we have with hydrolyzed diets. And ideally, when you're doing diet trials, you want to do it without any concurrent antimicrobials, which we shouldn't, they're in brackets because we shouldn't be doing anyway. And then without glucocorticoids, you want to try the diet on its own. So the initial diet choice for this dog was, with suspected chronic enteropathy, was a hydrolyzed protein dry food with a total dietary fiber of 1.37. So typically with the therapeutic diets, you will be able to get total dietary fiber from the product guide or by calling the manufacturer. So try and use that component if you have it available versus crude fiber. And then we gave the dog a fenbendazole course. So 6-week recheck, the dog did really well for the first 5 weeks. But since week 5, the colitis worsened again, and he vomited a couple of times. So what are we going to do now? The dog's not doing, is kind of, you could say, has failed that diet. And the owner's very frustrated. And this owner was not really prepared for, and we'll talk about this when we talk about compliance, but the owner was not geared up that there might be a second or a third diet in this dog's future. And she really wanted endoscopy biopsy as the next step. So we managed to convince her to let us try a second diet. And your choice here could have been fiber enriched. I really wanted to try fiber enriched as a second approach. Typically, when I have large bowel diarrhea cases, I usually try hydrolyzed first if it hasn't been tried, and then I try fiber enriched as my second category. I know some nutritionists who will try fiber enriched first. We're actually doing a study to compare dogs that have with large bowel diarrhea that have responded to hydrolyzed or failed hydrolyzed, responded to fiber enriched, just to see what the different characteristics are. You could have tried a second hydrolyzed diet. Certainly, we've had cases that have failed one hydrolyzed diet but responded to another one. You know, there's different ingredients, there's different fat fiber contents, and maybe that could have affected why they went into remission with the second. You could have done a novel protein. We could have thought about reducing fat. But for this particular case, I did fiber enriched as my second choice. There is a study that shows this is a trial and error approach, and we're trying to find clues in the history and, you know, the diagnostic investigations that help us determine what strategy is going to work, what's not for the patients. But at the moment, we don't have that information, so it is trial and error. But there is a study that shows up to 3 different diets may be needed in some dogs with chronic enteropathy before a response is seen. And that's really important to relay to the owner so they don't get frustrated when you recommend a second or a third diet. So we switched this dog over to fiber enriched, and from the left, what you can see is the feces when it was on a hydrolyzed diet, on the right when it was on fiber enriched. And this dog has been in remission for 2 years, at least 2 years on a fiber enriched diet, has done incredibly well. The owner is so happy. She sends us photos every month to keep telling us how happy she is with the fiber enriched approach and how it's maintained long-term remission. So the second diet helped this case, and that's kind of, so you may not always get success with your first diet, but it was good for us to kind of know that the hydrolyzed approach or the low dietary fiber didn't work. And so even sometimes you might try and get a diet history from the owner, and they may not be able to identify any diet that's helped or hindered the GI signs, and you've got no information to work with. It's not wrong to pick a diet from the category, because if it fails that diet, at least you have a data point of which strategies didn't work for that patient, because it is trial and error. So don't be worried if it takes the second or the third attempt. Sometimes just knowing that, okay, low fiber didn't help, now I'm going to try high fiber, that's what made us make that leap to fiber enriched as a second, which really helped this dog. So I'm now going to move on to ensuring compliance from owner and pet. So this is a really important area, particularly with owner in compliance and making sure that our diet trial is a success. So what we want to do, what I try and focus on when I'm speaking to owners about dietary trials, or when I'm trying to start a dietary trial, is again, three main areas. So the first is trying to center the conversation on educating the owner. So the first thing I'm going to tell them is the importance of diet in chronic enteropathy, how 2/3 of patients can go into remission with diet alone. It is a trial and error approach that's really important to relay, so they don't get frustrated if you recommend that second or that third diet. It's really important to stress to owners what's the repercussions of not taking the advice. So if they don't listen and they're not feeding the diet exclusively, what that might mean is we might then resort to glucocorticoids to treat the chronic enteropathy. And what we know from the literature is that dogs that respond to diet alone, their clinical disease activity reduces more than if they're treated with steroids. So their clinical signs are much better than if it was steroids, and their long-term prognosis is better than those dogs that are treated with glucocorticoids. So it's important to relay that to the owner. It's really important that we try diet, because the clinical signs will reduce more with diet versus glucocorticoids, and the long-term prognosis is better. So we really want to exhaust diet. And just really conveying to the owner that the recommendations we're giving is tailored to their individual pet, because a lot of owners don't see diet as something that's helping, like therapeutically. They don't see it as a treatment. But if you explain why you're picking the diet for their pet, then they kind of understand a lot of thought has gone into this, and then more likely to be compliant. Providing clear recommendations. I always say to my residents, think about diet as if you're prescribing a drug. Give the exact diet name. Don't say, we're going to pick a hydrolyzed diet, and then give every hydrolyzed diet in brackets and say, pick one. It's really important that you tell them exactly which diet you want them to feed. The reason that is because we know that there are dogs and cats that fail one hydrolyzed diet but respond to another one. So if you say to the owner, you can use any hydrolyzed diet, the message that sends is all hydrolyzed diets are the same. So if it fails the one that they chose, and then you're trying to get them to choose another one in that category, you're going to lose them, because they're just like, well, I thought they were all the same. So really important to give the exact diet name that you want them to feed. Tell them, is it dry or tin? The amount of times I see this missing, and if there is both available, it's just confusing owners, and they're just going to feel like, the clearer you are, then the more likely they're going to comply. Let them know how much to feed, even if it's just as a minimum. Follow label recommendations, adjust based on body condition, or even if it's just that, tell them the amounts to feed, how frequently you want them to feed, and how long we're going to do this for. We're going to do it for at least 2 weeks. We're going to do it at least and then reassess, or we're going to do it for 6 weeks and then reassess. Talk to them about treats. Typically we say no to treats. Some rare or uncommon cases we may say okay, but have that conversation. Let them know where they can get this diet from, because we've had instances where we've given them the diet, they finished the diet because the dog ate more than what we thought it was going to eat, and so we didn't give them enough. They didn't know where to get it from. They then go to the grocery store, the pet store, trying to find the diet. They find something that says hypoallergenic on the bag, and they think it's the same, and then they start feeding that. So really important to let them know that this diet is something you need to get from the vet practice. This might feel like a lot of information again to convey to the owner, so you can have a nurse or a technician deliver this information, or you can write it out as a handout, and then you can just ask the owner to sign, just to make sure that they've read everything. And then finally, just making sure that when you're relaying that information, it's relationship centered, checking in with nonverbal cues, checking in with their thoughts, addressing the worries. The amount of times I've had owners say they don't want to do a diet trial, and the reason is because they think their dog or cat has to stay on that diet for the rest of its life. But they've not told you that. They've just been really reluctant. So just really trying to ascertain what's the concern. And you can talk to them about how the majority can transition back to their regular diet or an over-the-counter diet. It just doesn't mean they have to stay on it for lifelong. Signposting, following up, letting them know how to follow up, and forward booking. So what we do is we always say 2 weeks. We're going to schedule a telephone call, 6 weeks, you're going to come back. We can cancel depending on how they're doing. But forward booking just gives them something that they know that this is a finite period. This is what's going to happen. And so I'm going to be really compliant during this time, hopefully. And then ensuring pet compliance. So again, you'll notice the theme in this presentation is threes. So again, I focus on 3 areas. So environment, food, and appetite. So with the environment, this is particularly pertinent with cats, really ensuring that they have an environment that's stress-free. With dogs, what we say is you can try using a dinner plate to feed the food if they're not really readily eating it, the kind of same dinner plates that you would use. You can use social competition if they have other dogs in the house or family members. You can ask them to time feeds when the family sit down to eat, because that might help as well with social competition with food intake. In terms of the food itself, what's really helped us with cats is doing a slow transition over 2 to 3 weeks. That can help with acceptance. Warming the food, adding water, picking formula. So this is why it's important. We talked about the diet history to get that preferences up front, to try and mimic those like preferences in the diet you choose for the trial. So the flavor or the texture, picking a formula that meets that so that it's more likely that the pet will eat it. Using a novel protein because it might be more palatable, thinking about that. And then finally focusing on appetite. So this is kind of pharmacological approach, thinking about stimulants. So appetite stimulants, and metazapine, palatine enhancers. We use Fortiflora for this a lot, where we make a warm water gravy with Purina Fortiflora, and we put it over the dry food, and that really helps with our cats. And with cats in particular, using anti-nausea medications, thinking about optimizing analgesia if you think that's a reason for low intake. So really, those are fine to use in the diet trial, and then you can take them away as the patient's going into remission. So finally, what I'm going to focus the next 10 minutes on is just how do we assess response and the next steps. So assessing response and next steps, I break this down into 2 factors, so pet-related factors and owner-related factors. So the pet-related factors that I'm looking at is, has that patient, if it was a patient that was losing weight or had a low BCS, is it gaining weight? Has it reached ideal BCS? What are its gastrointestinal signs looking like? And we use those disease activity indexes, and we'll look at this in the next slide, to try and objectively quantify the GI signs. And we don't have a consensus on the definition of full remission, partial remission, no remission. But there was one study that looked at the disease activity index. And if there was a more than 75% reduction, they defined that as full remission, partial remission as between 25 and 75%, and a less than 25% reduction in activity index as no remission. I think it's really important to take into consideration owner-related factors. The amount of time I ask my owners, what % improvement do you think there's been in the GI signs? And then I compare that to the CCI or the disease activity reduction. And sometimes they just do not equate. And that may be because of owners may have unreasonable expectations. And it's interesting, we get some owners where the disease activity has reduced by 90%, and in their impression, it's only improved by 20%. And so it's important to know that, because if that's an owner that has unreasonable expectations, it's kind of just making sure that you let them know that we may not be able to meet that. Or you might sometimes have an owner where they're like a 90% reduction, but the disease activity is only reduced by like 30%. And then, I've sometimes had owners who've come in and they just want to be able to pick up the feces, and if it's going 8 times a day, they're fine with that. So it's really important to kind of get their input and see how that correlates. And also perception of quality of life, because that's really, really important when we're trying to assess how the patient's doing and how it's responding to the diet. And you can get online questionnaires and surveys for quality of life. So these are the clinical disease activity indices. If you've not seen them before, we have two for dogs. It's CIBDAI and CCEAI, and we score each kind of variable out of 3, so mild, moderate, and severe, looking at the different gastrointestinal signs. What you'll notice, so that the one on the left is dogs, one on the right is cats. What you'll notice is that these look at weight loss, they don't look at weight gain. So if you're using these, it's important to make sure the patient's gaining weight and it's reaching ideal body condition, is muscle condition is improving, and also taking quality of life into consideration, which these disease activities don't. So I'm just really quickly now going to walk through 3 scenarios. So one where we have a patient in full remission, what do? We have a patient in partial remission, and we have a patient in no remission. So this is a dog that came into us with protein-losing enteropathy, and you can see just based on this picture, has low body condition, low muscle condition, and has dull coat. And we treated this dog with the hydrolyzed protein moderate fat diet, 6 weeks exclusively, nothing else. And the dog went into remission, so biochemically and clinically as well, and the dog gained weight, and you can see its muscle has improved as well, its coat is shinier. So this dog, we would say, is in full remission. So this is a dog with protein-losing enteropathy. And so we published a study a couple of years ago where we looked at dogs with protein-losing enteropathy. We looked at 3 categories. We looked at one where the dogs go into full remission and they stay in remission, sustained remission for at least 2 years. Dogs that went into remission, both biochemically and clinically, but they came out of remission, so they relapsed, and then dogs that never went into remission. And what we found is that dogs that stayed in sustained remission, the owners were more likely to adhere to the dietary recommendations. Dogs that relapsed were more likely to scavenge, or owners were changing the dietary recommendations. So when we have a protein-losing enteropathy case that responds well to diet, we usually encourage the owner to stay on that diet long term, because we worry that if we move away from recommendations, they could relapse. If it's not a protein-losing enteropathy case, it's a chronic enteropathy case, then what the studies suggest is that the majority can be transitioned. In terms of the time period, we usually say 12 to 14 weeks after they've had that diet exclusively. It might be sooner, we just don't have the data. So with the chronic enteropathy cases, we give, the ones that go into full remission, we give the owners the option. They can either stay on the diet if it's complete imbalance, which typically they are, or they can try transitioning over to another diet and see what happens to the clinical signs. But with the protein-losing enteropathy ones, we try to encourage the owners to stay on the diet long term. The next one is partial remission. This is when they have this 25 to 75% improvement. What do we do here? This is an example of a dog that had granulomatous colitis that went into remission, but then it would sporadically have colitis episodes occasionally, and they were increasing in frequency, and the granulomatous colitis was in remission, and we changed the diet to a hydrolyzed diet, and the dog did well on the hydrolyzed diet, but it didn't quite get up to that 75% improvement. And then we added a mixed fiber source, and the dog did really well on that, where all the stools were normal. And so in those cases where there's partial remission, depending on that percent and depending on the clinical signs, sometimes I might add a fiber source to see if I can get if I can increase that improvement, or sometimes you might think about using a probiotic with the diet before even just switching out the diet. So you may consider that in those scenarios. This is just a picture showing you the difference before and after incorporating the fiber supplement. And then we have this scenario where there's no remission, which is frustrating. And the question I commonly get asked is, how many diet trials should I try before I say this is not food responsive, or before I move on to endoscopy biopsy if we haven't performed that, or we move on to prednisolone or steroids? Typically, I say to try 3 to 4, but this is based on a case-by-case basis, because really we need to see what is the patient doing, because if it's developing hypoalbuminemia or there's the clinical signs are worsening, we're not going to keep doing diet trials. We need to get to the bottom of what's going on and we need to treat the inflammation. So this is just a general, I don't like to put a number on it, and I'll explain why in the next slide, but really we have to take it case by case. If I was going to use 3, typically what I've done in the past is I've used 2 hydrolyzed diets, because I feel like if they don't, I've had kind of success. If they haven't responded to one, they respond to the other one. If it's large intestinal, then I might do 1 hydrolyzed, 1 fiber enriched. But again, the diet history is going to help me in how they've responded. I might try limited ingredient as well. So again, it just depends on the case. So this is an example of a cat that had large bowel diarrhea. Initially, it had a hydrolyzed diet with kind of moderate for a cat total dietary fiber, and didn't go into complete remission. You can see on the left. So you would say no remission based on the percentage. We then dropped the fiber, didn't help. And then we went with fiber enriched and stools improved perfectly. So example of a cat that needed 3 diets trials before we found the one that worked for this cat. So this is just giving you an example, those ones that have no remission, how, you know, sometimes we do persevere and we can find the diet that helps. What I think really helps is using a table and listing different characteristics of, you know, each case is going to be different, but for this cat, it was the frequency of defecation. This cat had pain and straining cries, so those were important for this case. And just listing the categories, you might want to list ingredients, fat content, total dietary fiber. I always say a photo is really nice. It paints 1,000 words. I can't remember what the expression is, but sometimes when you ask owners to describe things, they don't always get it right, or their interpretation of diarrhea is different. And I think a photo paints 1,000 words. So I feel like a photo gives you more information. So having something like this could help guide you in terms of what the next strategy may be. And this is just an example of what I said about the moderate fat fiber content. So just using that table can help. And then this is the last slide. So I talked about, I'm reluctant to put a number on how many diet trials you need before we say it's not food responsive. So I've just wanted to say, beware. Don't change diets just for the sake of changing diets to reach a magic number. We do want to see some logic behind that. We want to see some justification for changing strategy, some improvement like we did for that cat. And the reason that is, why is that? The reason is because we recently published a study in cats where we showed cats with colonic fibrosis, if they developed colonic fibrosis, they were less likely to go into remission, more likely to die from their GI disease. So what I worry about is if we're looking at if this is the case in dogs. So we have a study going on at the moment to see if this is the case for dogs. But in cats, if we're just, you know, using different diets, just trying to get to this magic number, and this inflammation is ongoing in the background and diet just isn't helping, and we're just trying to reach this magic number, what could happen is if that cat develops fibrosis, it could ultimately affect its prognosis. So we really need to take it case by case rather than meeting that number. Thank you. Is my references?